Let's continue our set of lectures. So it's a second lecture of inflammation and repair topics. So here we continue following this book. So what is chemotaxis of leukocytes? In previous lecture, we discussed that leukocytes are hemotactically attached, hemotactically follow the inflammation, and so which chemoattractants for leukocytes we have? We have bacterial products, so for example peptides with N-formylmethionine termini. So most of bacteria, they possess this N-formylmethionine termini, a specific pattern of bacterial infection, and that's why neutrophils are following these products. Okay, then cytokines, especially those of chemokine family, so macrophages and other inflammatory cells in the site of reaction, dendritic cells also, they produce different cytokines, and neutrophils are following these chemicals to facilitate their function. Then components of the complement system, particularly C5a. So we'll discuss complementary system, but keep in mind that complementary system is a system of proteins which are dissolved in blood, and they are waiting for their activation as a response to inflammation. Then products of lipoxygenase pathway of arachidonic acid. Metabolism, particularly Catrian B4. Sorry, components of complement C5a is their types of protein. Sorry. Let's return back. Products of the lipoxygenase pathway of arachidonic acid metabolism, particularly Catrian B4, LTB4. So this you remember that in inner cell membrane we have residues of arachidonic acid, which are attached to lipids to in this double. So you remember that cell membrane is double layer of lipids, and the lipids they might possess arachidonic acid, like one of fatty acids which are attached to this lipid, and we have specific cyclooxygenases and lipoxygenases, so which destroy these lipids and use arachidonic acid of this lipid to produce leukotrienes, so also prostaglandins, and we'll discuss it in this lecture, and also they produce the thromboxanes. Okay. So these chemoattractants are produced by microbes and by host cells in response to infection and tissue damage and during immunologic reaction, all like by binding to 7 transmembrane G protein coupled receptors on the surface of leukocytes. So, and signal which is made by this, change the conformation of cytoplasm and cytoskeleton, and due to this it creates the motion of the cell, and it by pseudopods, same as amoeba in amoeba. So they start to traverse towards the bacteria. Okay, that's it about this point. Later, next part we'll discuss what is macrophage. Let's talk about summary of yesterday lecture and this introduction. Leukocytes are recruited from the blood into the extravascular tissue, where infectious pathogens or damaged tissues may be located, migrate to the site of infection or tissue injury, and are activated to perform their functions. Leukocyte recruitment is a multi-step process consisting of loose attachment to enrolling and on endothelium mediated by selectins, and then following with firm attachment to endothelium. It's integrins. So please remember selectins. So all types of selectins were discussed in previous lecture, and what is integrins. So, and how they're activated. So you see, try to remember this way, that selectins are activized on endothelial cells first of all. So 2 of selectins are produced on endothelial cells as a response of inflammation, and once selectin ligand is produced, so L-selectin ligand is produced on endothelial cells, E and P selectins are produced on the surface of endothelial cells as a response of inflammation. But on leukocytes, we already have ligands for P and E selectins, and also we have and also expressed L-selectin on the surface of leukocytes, but they are inactive. L-selectin is active, and only when revealing of L-selectin ligands goes. So only in this case, neutrophil starts this rolling process. Okay, but firm attachment to endothelium is happened with the help of integrins. Integrins, they are silencing during the normal life of neutrophils, but after the activation by cytokines, they can firmly attach to the endothelium and then facilitate the transmission of neutrophils through the cell, through the endothelial wall. It's also discussed in details in previous lecture. Whereas cytokines promote the expression of selectins and integrins ligands on endothelium, so like TNF, once again it's tumor necrosis factor, and interleukin-1, increase the avidity of integrins for their ligands, so they are chemokines, and promote directional migration of leukocytes, also made by chemokines. Tissue macrophages and other cells responding to the pathogens or damaged tissues produce many of these cytokines. Neutrophils predominate in the early inflammatory infiltrate and are later replaced by monocytes and macrophages. That's we'll discuss right now. So here on this microphotograph, we can see this as it's early neutrophilic infiltrates and congested blood vessels. You see blood vessels are increased, and leukocytes. You see this looks like multinucleated cells, but they are segmentonuclear, so polymorphonuclear leukocytes entering in out of the blood vessel wall. So it's a sign of acute inflammation here. But here you see this mononuclear infiltrates. Mononuclear, it means monocytes and macrophages. When monocytes is present in blood vessel, it's known as monocyte. And when monocyte enters into extracellular matrix, it is known as macrophage. So when it's entered into the connective tissue, I mean. Okay, and this approximal kinetics of this. So very acute reaction is edema. Then it followed with neutrophils infiltration, and gradually from beginning monocytes also going in the site of inflammation, but it reaches the crisscross of this reaction goes between first and second day. Of course, we have exceptions. We have a lot of exceptions. For example, in viral infection, we used to collect more macrophages and lymphocytes instead of neutrophils in the area of damaging. Also, in cases of autoimmune disorders, more lymphocytes and macrophages collected there without avoiding the stage of neutrophils. And also, example of allergic inflammation. In allergic inflammations, first of all collected eosinophils in the site of inflammation instead of neutrophils. There are some exceptions are present, but main idea that main direction that we have first reactive cells like neutrophils collection, and after this monocytes gradually replace them, because function of monocytes and macrophages is more sufficient, more important for us than neutrophils. And neutrophils are collected in this area, so first of all because they are more numerous in blood count. Secondly, they respond to cytokines much faster than monocytes. And bad side of this issue that neutrophils they can create the necrosis of tissues themselves. And so when too many neutrophils are located, you remember that in neutrophils we have a lot of lysosomes, and they can be released outside, and it causes the killing of tissues in this area. Okay, this will be discussed a little later, but this is but keep in mind that collection of neutrophils later might cause the formation of pus. So this pus formation. Okay, then phagocytosis and clearance of offending agent. So how it goes. Recognition of microbes or dead cells induces several responses in leukocytes that are collectively called leukocyte activation. So how does leukocyte activation goes? So especially Okay, after leukocytes, particularly neutrophils and monocytes, have been recruited to a site of infection or tissue injury, they must be activated to perform their functions. This makes perfect sense because while we want our defenders to patrol our body constantly, it will be wasteful to keep them at a high level of alert and expending energy before they are required. So we need to give a rest to these cells because actually overexpression of these cells might cause the normal cell injury. That's why we keep them safe, but only in case of inflammation we activize them. And how this activation goes, let's discuss it right now. Okay, in easy words, N-formylmethionine peptides. I remind you, it's usually located in microbes. So when microbes during the microbe activity, they produce these peptides. They're present in cell wall of these microbes. We have chemokines, which are released by injured tissues, and lipid mediators. So also, what we discussed, it's for example. Um, it's our lipoxygenase by lipoxygenase produced produced compounds. They activate the G protein coupled receptors. It's in neutrophils first of all, and then it causes a cytoskeletal changes signal transduction, and it causes chemotaxis and migration into tissues. And in other hand, they have increased integrin avidity and adhesion to endothelium. So that's we discussed in previous part of lecture. But also on the surface of neutrophils and macrophages, we have toll-like receptors. We will started to talk about this. These toll-like receptors. So they have a special affinity to CD14. So what is CD14 we'll discuss a little later. And microbes with lipopolysaccharides, so with specific lipopolysaccharides on the surface, they are attached to the CD14. It's like antigen actually, and then it activates the toll-like receptors, and then phagocytosis of the microbes goes much faster than before. Then cytokines like IF and interferon gamma, they activate the cytokine receptor, so interferon gamma receptor, and it leads to production of reactive oxygen species and lysosomal enzymes. So must be our cells get activated to digest these residues of cells, or might be bacteria or any offending agent, and also leads to production of mediators, so metabolites of arachidonic acid and cytokines, and it causes the amplification of the inflammatory reaction. And additionally, interferon gamma, so as I said, produce reactive oxygen species and lysosomal enzymes to kill this bacteria, and later it causes microbicidal activity of leukocytes. These lysosomes and reactive oxygen species are used by neutrophils especially to kill this bacteria. Okay, we have phagocytotic receptor, as we discussed in previous lectures and in previous classes. We have specific phagocytic receptors which facilitate the phagocytosis here. So activation of this receptor causes the invagination of invagination of cell membrane and descending it into deep of cytoplasm. And then phagocytosis goes into phagosome, and same activity, microbicidal activity, killing of microbes. So that's the main idea. Let's continue. So without bothering here. Recognition and attachment. So how it goes? So everything is similar as we discussed in phagocytosis. So this bacteria, when it's attached to phagocytic receptor, this bacteria get engulfed inside the cytoplasm. So phagosome is present here, bubble of phagosome. Then this phagosome is joined with lysosomes with enzymes, and then this bacteria get digested by these proteolytic enzymes in phagolysosome. Okay, Also, don't forget that these lysosomes are using they use reactive oxygen species. And reactive oxygen species are produced in this way. So they might be produced in specific pathways. So we have cytoplasmic oxidase, and which uses H pluses, and membrane oxidase is activated by this, and oxygen, normal oxygen is present inside the cells, is is changed into oxygen, radical oxygen. And as we discussed earlier, reactive oxygen O2, reactive oxygen radical, connected with water, form the H2O2, hydrogen peroxide. And H2O2, under the influence of iron, it produces OH radical, and under the influence of chlorine anion, might produce hypochloric radical. And but both of them are very dangerous for formation of for cell membranes of the bacteria. So, and same here, phagocyte oxidase we have. So oxygen changing in reactive oxygen species, one of them. And also we have an arginine as donator of nitric oxide, also is active product which can destroy the cell membrane and cell wall of the microbe. So that would actually we discussed it. So let's talk about intracellular destruction, microbes and debris. Yeah, we discussed it. Actually, we discussed it in more details. Please read this book. Inside this book, you can find all the necessary all the necessary information. Granulozymes and other proteins. Neutrophils and monocytes contain granules packed with enzymes and antimicrobial proteins that degrade microbes and dead tissues and may contribute to tissue damage. So here I want to give you a little break, and in this break I want to mention one thing. If you watch this video until this moment and watch it attentively, so name me, so in a practical class, say to me the word fridge, and I can be sure that you watch this video till the at least middle side. Okay, it will be a plus point to you in practical class. I give you mark +1. Okay. Then let's continue. The granules are actively secretory and thus distinct from classical lysosomes. Neutrophils have two main types of granules. The smaller specific, and also named as secondary granules, contain lysocene, collagenase, gelatinase, lactoferrin, plasminogen activator, histaminase, and alkaline phosphatase. And larger azurophil granules, they contain myelin peroxidase, bactericidal factors, acid hydrolases, and a variety of neutroproteases, which are elastase, cathepsin G, non-specific collagenases, proteinase 3. And these phagocytic vesicles containing engulfed material may fuse with these granules and with lysosomes as described earlier, and the ingested material are destroyed. So that's okay, that's not interesting. So actually, main idea is that lysosomatic proteolytic enzymes and hydrolytic enzymes can destroy all the components of bacterial cell. Okay, and this specific, very specific thing. So please remember it for once and forever. Neutrophil extracellular traps. Neutrophil extracellular traps are extracellular fibrillar networks that concentrate antimicrobial substances at sites of infection and prevent the spread of the microbes by trapping them in the fibrils. So this mechanism, this is fascinating. So please try to pay attention. These traps are produced by neutrophils in response to infectious pathogens, bacteria and fungi, and inflammatory mediators to chemokines, cytokines, and complement proteins, as we discussed earlier. Extracellular traps consist of viscous meshwork of nuclear chromatin that binds and concentrates granule proteins such as antimicrobial peptides and enzymes. So let's translate it into easy words. Neutrophil sacrifice their nuclear components, just burst their nuclear components into the into the extracellular matrix, and on the surface of this DNA are located proteins, and they use their own chromatin just like debris, just like traps, for bacteria. So that's in very very fascinating thing. So they're sacrificing themselves for our living. It's like Jesus Christ in our body. I'm an atheist, so for instance. Okay, uh, so neutrophil extracellular traps provide an additional mechanism of killing microbes that does not involve phagocytosis. In the process of neutrophil extracellular traps formation, the nuclei of the neutrophils are lost, leading to the death of the cells, sometimes called netosis, representing a distinctive form of cell death affecting neutrophils. So nets are also have been detected in the blood during sepsis. The nuclear chromatin in the nets, which includes histones and associated DNA, may be a source of nuclear antigens in systemic autoimmune diseases, particularly lupus erythematosus, in which individuals react against their own DNA and nuclear proteins. Antinuclear antigens, so it's typical for them. So neutrophil extracellular traps. Please, I'll ask you about this neutrophil extracellular traps. What is the essence of this? Then leukocyte-mediated tissue injury. So leukocytes might kill our cells, might injure our cells. So as a part of normal defense reaction against infectious microbes, so when tissues at or near the site of infection suffer collateral damage. In some infections that are difficult to eradicate, such as tuberculosis and certain viral diseases, such as hepatitis, the prolonged host response contributes more to the pathology than does the microbe itself. Actually, here, I think in 2020 edition of this book, so they will join here coronavirus. So actually, collateral damage. So when our cells start to defend ourselves against these viruses, I remind you, they activate the apoptotic reaction. They activate the apoptosis of the cells by trapping their sorry. Okay. Uh, when the inflammatory response is inappropriately directed against host tissues, as in certain autoimmune diseases, so that's very common. And when the host hyperreacts against usually harmless environmental substances, as in allergic diseases, including asthma and some drug reactions. So, main idea that leukocyte activation is not always followed with healing. Yeah, sometimes it overreacted, hyperreacted, and so in cases of viruses, it's very important. For example, chronic viral. So let's discuss this example of hepatitis. You know that we have hepatitis C and hepatitis B, so they are chronic. So especially hepatitis C is chronic, and during this chronic injury, so what's the injury of this? So it's sometimes called as silent killer. So it has very slowly, so these viruses damage our, so they enter inside our cells, and our immunity cells try to figure it out, try to find these infected cells and kill them. And it goes very slow. Viruses can change their DNA, and due to this, after they change their genetic code, they change antigens, and that's why antibodies against these viruses can't work. And that's why very gradually this hepatitis C affect all the cells of liver, and our immunity works against it. They work against it and try to destroy the cells, and destroyment of these cells causing the fibrosis of this of these liver cells. It is also known as cirrhosis. Yeah, that's the main danger of this hepatitis C is formation of cirrhosis, because even if we treat this hepatitis C, so liver it causes the liver failure finally, and of course uh, death. So, but now we have treatment against hepatitis C. In India, actually, first of all, in USA and United Kingdom, they developed the very extremely so they created extremely expensive drug, extremely expensive drug. So approximately 100,000 of dollars for one course of treatment. And of course, not everyone can afford it to themselves. But in India, they made the analog of this drug, which costs approximately 200, $300 for the one course. And of course, nowadays in our country, I don't know how it's in your country, but in our country, we treat the hepatitis C very effectively in 98% of cases. But we should start the treatment before cirrhosis starts, because after the cirrhosis starts, so it's impossible to treat it. Okay, let's discuss it in a proper topic in pathology next semester, but just example should be noted. Okay, leukocytes damage tissues by releasing injurious molecules. Potentially toxic contents of granules are released by leukocytes into the extracellular milieu by several mechanisms. Controlled secretion of granule contents following degranulation is a normal response of activated leukocytes. So I remind you, granules of leukocytes are so specific and non-specific, and both of them might be released. And lysosomes, non-specific granules, also known as azurophilic granules, they contain hydrolytic enzymes which destroy the extracellular matrix and other cells. So that's why it causes the damage. Okay. Controlled secretion of granule contents following degranulation is a normal response of activated leukocytes. If phagocytes encounter materials that cannot be easily ingested, such as immune complexes deposited on immovable flat surfaces, so example is glomerular basement membrane, the inability of the leukocytes to surround and ingest the substances, it's known as frustrated phagocytosis. Uh, it triggers strong activation and also the release of large amounts of granule enzymes into the extracellular environment. So some phagocytosis substances such as urate and silica crystals may damage the membrane of the phagolysosome and also lead to the release of damaging contents. You see, lysosomes are damaged and release their contents. And frustrated phagocytosis also, don't forget about this. So on the surfaces, flat surfaces. So as reactions, so don't as a reaction includes the secretion of cytokines like interleukin 17. So later we'll discuss it. Then they induce the secretion of chemokines that recruit the leukocytes. In the absence of effective T17 responses, individuals are susceptible to fungal and bacterial infections, and the skin abscesses that develop are called abscesses. So cold abscesses lacking the classic features of acute inflammation such as worms and redness. So keep it in mind when you will find patient with these symptoms, with cold abscess. Then termination of the acute inflammatory response. Such a powerful system of host defense with its inherent capacity to cause tissue injury needs tight control to minimize damage. In part, inflammation declines after the offending agents are removed simply because the mediators of inflammation are produced in rapid bursts only as long as the stimuli persist, have short half-lives, and are degraded after their release. Neutrophils also have short half-lives in tissue and die by apoptosis within hours to a day or two after leaving the blood. In addition, as inflammatory develops, the process itself triggers a variety of stop signals that actively terminate the reaction. Okay, anyway, but after this activated the repair mechanism of the tissues, and so how it works, it will be more discussed in the repair topic. Okay, so I don't want you to I don't want to read the lecture, but I want to explain the lecture. So, and actually now starts a very huge topic, mediators of inflammation. I hope I will have time to over this inflammation, this part of topic today. Okay, summary about previous part. Leukocytes can eliminate microbes and dead cells by phagocytosis, followed by their destruction in phagolysosomes. That is noted in first way. Destruction is caused by free radicals, like reactive oxygen species and nitric oxide, generated in activated leukocytes and by granule enzymes. Then, neutrophils can extrude their nuclear contents to form extracellular nets that trap and destroy microbes. Neutrophil extracellular traps, so please remember this. Granule enzymes may be released into the extracellular environment and causing the external cell damage. The mechanisms that function to eliminate microbes and dead cells, the physiological role of inflammation, also are capable of damaging normal tissues. So it is point of next discussion. And capable of damaging normal tissues, the pathological sequences of inflammation. And anti-inflammatory mediators terminate the acute inflammatory reaction when it is no longer needed. So then let's talk about mediators of inflammation. We already talked about them and you approximately understand the function of them. First of all, they promote all these 5 events of inflammation. First of all, they cause the swelling, they cause the redness, they cause the pain, yeah, and also causing the heat reaction in this area. And gradually, like a result of these 4 reactions, we have loss of function of this organ. Okay, and they regulate and initiate and regulate inflammatory reactions. So that's it must be noted. So let's talk about each of them. Histamine. Histamine, as I said, is released by mast cells, basophils, and a little bit released by platelets. And the function is vasodilation, increased vascular permeability, and endothelial activation. So they activate endothelial to release these selectins and integrin ligands. That's one. And secondary, they relax the smooth muscle vasculature under the blood vessel, which leads to dilation of the blood vessels. Okay, then prostaglandins. Prostaglandins is resulted from prostaglandins are resulted from arachidonic acid degradation. Arachidonic acid degradation, so made by mast cells, also same mast cells, and other leukocytes. So all of them are responsible for prostaglandin secretion, and one of them, like prostaglandin E2, is responsible for pain sensation. But we have a lot of prostaglandins, and we will discuss some of them here. But I think it should be SAW or some report topic. So because they are so numerous and actions are so different that it can be explained in this lecture. Then leukotrienes. Leukotrienes are responsible for increased vascular permeability, chemotaxis, leukocyte adhesion, and activation. And they're produced also here, so they have leukotrienes are also produced from arachidonic acid, and by specific enzymes they changed into the leukotrienes or prostaglandins, and same cells are involved in this process. Then cytokines. Cytokines are more specific molecules which are produced by macrophages or endothelial cells or mast cells. They have their functions, and according to names we can conclude it. Yeah, so like TNF, interleukin 1, and interleukin 6. TNF is tumor necrosis factor, as been noted before, so it's taking role in apoptosis, and large amount of this tumor necrosis factor causing the apoptosis of the cells, affected cells, and it's released by macrophages or monocytes in the site of potential cell injury, and release and with help of TNF, cells commit suicide. I remind you that it's extrinsic pathway of apoptosis. Interleukin 1 and interleukin 6 are working as attractors of other immunity cells to the site of inflammation. So, local effect. It's endothelial activation, expression of adhesion molecules. I remind you this process of rolling, yeah. Then a systemic effect is a fever, metabolic abnormalities, and hypotension. So in case of shock, it will be our next lecture. So next set of lectures will be about shock. Okay, chemokines. It's a very large variety of chemokines are produced, and they are small molecules. They are less than cytokines, and that's why we don't want to discuss them in details. But main property of them that they invite the leukocytes to the site of inflammation, and they are produced by other leukocytes or activated tissue macrophages. They cause the hemataxis and leukocyte activation. For example, integrins, they are activated by these chemokines, which are produced by macrophages. Okay, and platelet activating factors. Platelet activating factors, so we require platelet adhesion in this area to produce clot. Sometimes it's required, and they are produced by leukocytes and mast cells. And function is vasodilation, increased vascular permeability, leukocyte adhesion, hemataxis, degranulation, exudative burst. That's their action. And okay, and they activize in the platelet formation. So later, keep in mind that inflammation inside the blood vessels is usually correlated with the formation of clots in a blood lesion. For example, in case of endocarditis, so platelets will be attached to endocardium of the heart and forming the clots which are constantly released from the site of injury. Then complement. Once again, about complements we have some very huge part of lecture. It is derived from plasma. So, but in plasma it appeared from the liver. So it's a usual protein which is produced by liver. You remember it's in physiology that liver producing globulins and albumins. And complement is part of globulin family proteins. And complement proteins they cause the leukocyte hemataxis, and I remind you C5a complement so is chemotactic for leukocyte, and activation of leukocytes also. Direct target killing, so membrane attack complexes. This complement is responsible for membrane attack complexes formation. These different complements they can accompany together. They very complicated system we'll discuss later, but finally they form the membrane attack complex, which destroys the cell membrane of our own cells or any host cells or might be offending cells. And by this, so of course, it promotes the cell death, or by apoptosis, but usually by necrosis. So this complement is used for autoimmune disorders. It's a very common type of reaction. Then kinins. Kinins are also produced in plasma, but they are activized only in site of inflammation. Example is bradykinin. Yeah, they cause the increased vascular permeability, smooth muscle contraction, and vasodilation and pain. So bradykinins like main mediator, so causing the pain. Mechanism of this will be discussed a little later. So, and here is the classification. Mediators may be produced locally by cells at the site of inflammation, or may be derived from circulating inactive precursors that are activated at the site of inflammation. So we subdivide in cell-derived mediators are rapidly released from intracellular granules, for example, amines, histamine, yeah, or synthesized de novo, so might be produced from the arachidonic acid. So actually, it's like so it's like precursor of prostaglandin, leukotrienes, and other components, thromboxane. It is arachidonic acid, but cytokines are produced de novo in response to a stimulus. The major cell types that produce mediators of acute inflammation are tissue macrophages, dendritic cells, and mast cells. But platelets, neutrophils, endothelial cells, and most epithelia also can be induced to elaborate some of the mediators. Okay, for example, plasma-derived mediators, complement proteins, are present in the circulation as inactive precursors that must be activated usually by a series of proteolytic cleavages to acquire the biologic properties. They are produced mainly in the liver, are effective against circulating microbes, and also can be recruited into tissues. Then active mediators are produced only in response to various molecules that stimulate inflammation, including microbial products and substances released from necrotic cells. Okay, as they are described earlier. Most of the mediators are short-lived. They, when they facilitate their function, we have specific enzymes to destroy these mediators because we need. It's aligned. First of all, acute inflammation aligned for short response, and when it's released, action happens, and then we destroy this. For example, histamine, which is produced, we have specific enzyme against it, a histaminase. So after the activity of this histamine happened, so histamine is reduced, destroyed by histaminase, so which are present in neutrophils and eosinophils. Okay, this built-in control mechanism are discussed with each class of mediator. One mediator can stimulate the release of other mediators. So that's always keep in mind that it's sequence of events. It's overlapping reactions happen there. Okay, once again, that products of complement activation stimulate the release of histamine, and the cytokine TNF acts on endothelial cells to stimulate the production of another cytokine, interleukin-1, and many chemokines. The secondary mediators may have the same action as the initial mediators, but also may have different and even opposing activities, thus providing mechanisms for amplifying or, in certain instances, counteracting the initial action of a mediator. So it's a complicated system. You already understand it, and even nowadays studies are aligned to understand the function of them. But keep in mind, this response goes after the large amount of a lot of time of the evolution process, and in evolution we use what we have, and that's why of course it will be complicated system that one is activating another, and this activating another, but also this activating another thing. So that's you see, it's complicated system, and different cytokines can cause another cytokine activation in different tissues. So that's why you can't learn it. You can't learn it by heart. You never remember it all forever. But at least you have to understand this complicated system. That this is complicated system of activation. But main of them we will discuss right now. Then vasoactive amines, histamine, and serotonin. The two major vasoactive amines, so named because they have important actions on blood vessels, are histamine and serotonin. They are stored as performed molecules in cells and are therefore among the first mediators to be released during inflammation. The richest sources of histamine are mast cells, which are normally present in the connective tissue adjacent to blood vessels. Histamine also is found in blood basophils and platelets. It is stored in the mast cells granules and is released by degranulation in response to a variety of stimuli, including physical injury such as trauma, cold or heat by unknown mechanisms, binding of antibodies to mast cells, which underlies immediate hypersensitivity or allergic reactions, and products of complement called anaphylatoxins, so described later. So, and neuropeptides like substance P and cytokines also may trigger release of histamine. That's the point. So later in clinical subjects, you'll discuss what is substance P and how it is responsible. Then histamine causes a dilation of arterioles and increases the permeability of venules. Histamine is considered the principal mediator of the immediate transient phase of increased vascular permeability. Remember the diagram. I'll try to show it to you. In beginning of lecture, I shown it to you. So here. No, not here. Yeah, this diagram, I mean. This diagram, you see, it's all this first process which happened in the acute reaction is mainly caused by histamine releasing in these tissues. So this peak of edema and penetration of plasma components into the extracellular matrix of connective tissues, it is all of this is happened with help of histamine. Okay, once again, I repeat the word fridge. So in the end of lecture, if you say to me that you said fridge, how many times I said fridge in this lecture, you can say to me in practical class, and it will increase your mark. Okay, then finally, let's talk about arachidonic acid metabolites. Arachidonic acid metabolites, they're lipid mediators known as prostaglandins and leukotrienes. They are produced from arachidonic acid present in membrane phospholipids that are stimulate vascular and cellular reactions in acute inflammation. So I noted it before. So we have phospholipids and two residues of fatty acids are present, and some of these fatty acids are arachidonic acid. Not a lot, but some of them. And they can trigger the activation in acute inflammation. Arachidonic acid is a 20-carbon polyunsaturated fatty acid derived from dietary resources and conversion from the essential fatty acid linoleic acid. So we have to get it in our body. That's why you might be heard that against the viruses, against some tuberculosis, might be you should eat some so different types of fats, so animal fats. So might be I heard about so sheep fat. I also heard about the fats of dog's fat, groundhog fat. So I don't know. I never eaten it, but a main idea of this that they are donors of these phospholipids. They're donors of arachidonic acid or might be linoleic acid, and from them we can use it to produce this arachidonic acid metabolites. And these mediators which are produced from arachidonic acid, they're known as eicosanoids. Please remember this term, eicosanoids, um, and synthesized by two major classes of enzymes, cyclooxygenases and lipoxygenases. Eicosanoids bind to G protein coupled receptors on many cell types and can mediate virtually every step of inflammation. They are numerous in production, and that's why we have to remember them. Okay, prostaglandins are produced by mast cells, macrophages, endothelial cells, and many other cell types and that are involved in vascular and systemic reaction of inflammation. So we have different prostaglandins and they are activated by cyclooxygenase. Okay, let's take a look. So phospholipases, they destroy with help of steroids. Steroids opposite to this, they disrupt the phospholipases activation. So steroids, drugs, I mean glucocorticoids we give to patients, they stop the activity of phospholipases, and that's why cell membrane doesn't release this arachidonic acid. Then an arachidonic acid undergo the two pathways, cyclooxygenase pathway and lipoxygenase pathway. And okay, in cyclooxygenase, so this one is most we should know about. We have COX-1 and COX-2. This cyclooxygenase, which produce different types of products. It's prostacyclin, thromboxane, and prostaglandin D2, prostaglandin E2, prostaglandin G2, prostaglandin H2, which are produced, and their activity is different. So here you see the activity. Prostacyclin causes vasodilation, inhibits platelet aggregation. Then thromboxane A2 causes vasoconstriction, promotes platelet aggregation. And PGD2 or PGE2 causes vasodilation, increase vascular permeability. Okay, let's talk about things you remember. So if you have relatives elder than 50 years, so might be so in 50% sure that they're taking aspirin every day, 100 milligrams or 75 milligrams, so it depends. And it's necessary to dump this activation, thromboxane activation, because it causes vasoconstriction and promotes platelet aggregation. So you see, so dampening of this pathway, so don't only decrease the inflammation, but also causing the loss of platelet aggregation. Thromboxane promotes the platelet aggregation, but these drugs prevent this pathway, and that's why aggregation is decreased. This anti-aggregant drugs work activity. And we have lipoxygenase, so which produce leukotrienes, and different types of leukotrienes are responsible for bronchospasm, increased vascular permeability, and so on. And also lipoxins, they inhibit of inflammation. That's especially present, so like specific activity which is caused by different interleukins, so I mean cytokines, which helps us to release this lipoxin in repair condition. Okay, without stopping on this for a long time, what is the leukotrienes, what is the lipoxins, so you should read it by yourselves. And now I want to stop my lecture on this point, cytokines and chemokines. What are cytokines and chemokines, and how are they working there? Thank you for attention. Don't forget about surprise I gave you in these lectures. So in practical class, I hope you will answer this question to me, which is present in the middle of this lecture. Okay, thank you, goodbye.